Hello everyone and welcome to Rad Chat, the first therapeutic radiographer-led oncology podcast. So welcome to podcast number 48. My name's Jo McNamara and I'm joined by fellow host Naaman Jolka Anderson. So a huge thank you to our last guest, Dr. Lisa Whitaker, who talked about the Radiation Reveal project. If you haven't yet had a listen, please do go and take a look. So we're really pleased to introduce our guest for this evening, Pete Wallroth, who will be talking about his role at the wonderful charity Mummy's Star. So hi Pete, thank you so much for joining us.
Evening guys, thank you.
So anyone who listens regularly to the podcast will notice that Mummy's Star has been mentioned a lot by lots of our guests. So it's great to finally have you on and kind of show and give the recognition that this charity obviously deserves. Pete, before we talk about the charity, can you maybe tell us a little bit about yourself and what your current role is at the charity?
Sure. So yeah, my name is Pete Wallroth. I'm the CEO, founder of the charity Mummy's Star, which supports families diagnosed with cancer in and around pregnancy. So any stage during pregnancy with a diagnosis or up to 12 months postnatally. And I've been doing this now for coming up to 10 years. So quite a significant anniversary coming up for us all as a team. And I suppose outside of that role, most importantly, I'm a dad of three. I've got three, a girl and two boys. I'm a very keen runner. Spend most of my time when I'm not sat at my desk in the hills. Much to their jargon, really. They probably wish I was sort of actually around at home a bit more often. But yeah, it's a really, I'll obviously explain a little bit more. But Mummy's Star is just it's opened up quite a niche within an already fantastic cancer sector that offers an awful lot to so many people. But this was an area that needed tapping into, due to a personal situation that unfolded, just coming up to about 10 years ago in June this year. So, and everything has kind of snowballed since then in terms of the what we do and how this charity has grown over the years.
So Pete, what do you do? So we ask this question of lots of CEOs. And I think when you say I'm a CEO, I think people think you sit at a really large desk and you spend all your time writing emails and doing fundraising. But I know the role is a lot bigger than that. What is it that your day looks like?
Oh, it is literally everything. I think because I'm the founder of a relatively small charity. It's everything, hands in everything. So I might be meeting my fundraising manager when we'll be talking about sort of different things that people are doing for us, how families are supporting us that we've supported in the past, how friends have, learned whether it's from a local area, people running I got contacted by a walkers group yesterday doing something to, locally to support us to, sort of a national event that people are wanting to, sort of represent the charity at. It might be talking to somebody last week to, a European project that we're partnership in terms of looking at some research that's linked into the International Cancer and Pregnancy Network. But I suppose the most important thing that I still am involved in on a day-to-day basis is actual supporting caseload. So even though we've got a number of in the team, I still support any families that we get that come from either Northern or the Republic of Ireland. So supporting those families on a day-to-day basis from diagnosis through to their treatment plan unfolding in front of them, trying to help them map out sort of where support will be needed. Also supporting partners as well across the board, because I have an insight that the rest of the team don't, in terms of actually what it's like to be a partner supporting somebody through a cancer diagnosis. Its involvement in policy work, making sure that the families and the situation that we support families through in terms of cancer and pregnancy is better represented within the national sort of various cancer alliances, with things like Cancer 52, where it's a rare situation within, not so much rare cancer, but it's a rare situation within the cancer world. And ultimately all of us together is with the aim of broadening an understanding of firstly, that cancer and pregnancy does happen. You still, even after 10 years, I do still come across people who just struggle to fathom that this is even possible. Because we hold pregnancy so sacred, understandably, and I think we've falsely fallen into the trap of thinking it's somehow immune to illness, outside of, say, things like diabetes and some other health issues that people might already have. It's the occurrence of a cancer in pregnancy that I think is where I'm certainly spending an awful lot more of my time in the last couple of years, is working on education, working with universities, delivering guest lectures, non-clinical based lectures on cancer and pregnancy as a subject, and where different levels of the health profession can step in, whether it's midwifery, whether it's health visitors, whether it's therapeutic radiography, oncology, a CNS. It doesn't matter who is involved. If you're involved within the maternity sphere, there's a role you can play, and it's about trying to broaden the understanding across the board of a relatively untouched subject, and an often misunderstood subject as well, in terms of what you can and can't do and what the options are for families.
And you might see when you go back to your inbox, I've just requested one as well, actually, for the university I work at as well. So yeah, and I think absolutely, I think education is always going to be something that I'm extremely passionate about, but hopefully getting whilst people are training is so important to be able to provide them with some level of experience of things that they might not see clinically, but be able to use that patient voice or those experiences to then shape maybe how they will deal and support patients who are going through something similar.
Absolutely. I love doing the education sessions. It's built up. It started as we get the occasional invite to do something at a midwifery society a few years ago, and then before COVID, it had started to build up. It was quite frustrating, actually, because we got into the start of 2020, and I literally was delivering a talk every other week, and it was a fantastic momentum. And then all of a sudden, COVID happened, and I remember delivering my last session on I think it was the 13th of March in Nottingham to the Midwifery Society, and then their university was literally starting to shut down that day in advance of what was inevitably going to happen. But strangely, the momentum didn't stop, because they had the ability, the universities, to shift to that hybrid learning, and and it still remains so, largely with many of them that I'm working with. It broadened the audience, because we had so many more students that could access it online. And I suppose the challenge is always, if it's a midwifery society, because of the voluntary nature of it, the students themselves, they never knew whether they'd have 10 or 25 or 50 turn up. Whereas as soon as we went online with it, I had like 50, 60, 70, 90 students at times attending a session, and it was fantastic to get that audience and to be able to, I think, hold the attention because of the nature of the subject. I think it isn't one where there's a drift over the course of it. I think because we go through, live case studies to try and illustrate how people can make a difference. But just the point you just made there, I think before they've got into practice, it's always really interesting when I run an interactive kind of role play with some students, where I give them anonymized examples of, say, something like a woman's been diagnosed at 29, second pregnancy, this is a previous pregnancy history, and this is the diagnosis, what would you do? And it's always interesting to see that when you hear it from a student voice, they go with their instinct. They haven't been surrounded by any practice, positive or negative, yet. They haven't had to work within strict parameters, so they go with their instinct. Everything is all about compassion, about informed choice, about listening to that family, and to the how does that person want to give birth? Where do they want to give birth? What are their fears and aspirations about that pregnancy? Whereas when you do it sometimes with an existing group of health professionals, they've been bound by parameters that have been set by their trust or the way they've had to get used to working over the years, and you get a slightly more restricted viewpoint. And I think that's what's really good about being able to encourage, especially student midwives, because historically I think midwifery hasn't seen itself as having a role within cancer, perhaps, to be able to really show them that this is how much of a difference you can make. You're not going to be an oncologist. We're not creating a midwifery oncology nurse specialist role. But what we're trying to offer is an illustration of, as I've heard the phrase so many times, that you're not just a midwife. You are so much more than your role dictates, because you're inside, and if you just follow that compassionate care, it just opens itself up in this situation. And also the midwife offers that really powerful conduit between perhaps oncology, radiography, and obstetrics, whereas it's just that I'm here to represent that person who's going to give birth and their family. And where sometimes there's a disconnect when a cancer diagnosis happens in that particular situation. So yeah, the education aspect of it is it's building and building and building. It's really, really, really positive.
We find now that with a lot of their health education training that we do a lot of integrated sessions, and I always remember the midwifery students and the therapeutic radiography students going, we would never work together. And I just go, what? Absolutely, of course. There are going to be times that you will benefit from working collaboratively together. And it's just really interesting when you see those light bulbs going off, going, oh yeah, we've never really considered that. And definitely, I think that's where, from your perspective and what you're training people to do, really comes into play, to kind of break down some of those barriers and look at how we can do more integrated, personalised care. Is that something that you found within your own experiences, Pete, in setting up kind of Mummy Star and going through that?
Yeah, I think when we look back on it, and when I do those sessions with students now, the standout example that I always give of what I would perceive to be positive care, if every family were looked after this way, then that would what would the aspiration would be. It always goes back to myself and my late wife Maya's situation in terms of how when we received our diagnosis. How was that diagnosis actually? How did it come about? Who were the people who were integral in that happening? So, for example, something we're going to be working on later this year in terms of our Awareness Week campaign that we do each June is about, that every health discipline has a role to play. So how can a midwife be part of the cancer diagnostic pathway? Well, they can be the person she discloses that she's not happy with something. She's got something in the breast tissue that she doesn't feel right for her, but she might have had a different experience previously with a different part of the health profession, so she doesn't want to disclose it to them. But with the midwife, she's got that bond of trust and she's willing to disclose that. And for us, it was the midwife that Maya disclosed to actually said, I've just got this ache and I'm not entirely happy about it. And that midwife didn't hesitate. She just said, fine, I'll make a referral to the breast clinic. That's all we ask for. If that happened in so many other situations, it would make a significant difference. And from there, yes, we received a diagnosis. Yes, it was devastating. But when I look back at that objectively, the flow of how that process happened, it was 2 weeks. It was really, really swift in terms of the decision making. And I think that's what we now illustrate. Say, look, if you can move through the processes this way, and then midwifery plugs into this and says, this is what you wanted to do. Just because you've got cancer doesn't mean that's all off the table. If clinical reasoning comes in as to why something has to change, like you can't have a home birth anymore, for example, because we want to induce you to limit the gap between say final chemotherapy in pregnancy to first treatment after, then understandably there are reasons why that those decisions change and things have to be moved around. But it's all about the language, it's about the communication, it's about explaining to that family and saying, this is why we think this is going to be the best course of action for you. Now, unless you're treating an oncologist, 9 times out of 10, a family will say, okay, right, it's devastating, it's traumatic, but thank you for explaining it to us. And I think there's a subtle difference there between saying to somebody, this is what we're planning on doing, as opposed to just blustering in and saying, you're having chemo on that day and this day, and you feel done to as a patient. You feel like you've not had any input, any choice. We sat in our MDT as a family. We sat there with the obstetric team, with oncology, with CNS, with a paediatrician. We had about 12 different staff there. There was, of course, it was medical terminology that was being used, but just physically being able to be present in that room, it felt like we had a level of involvement. It was good to see that the example always comes back to me is that the level of steroid dose that was going to be deemed safe for her to have during pregnancy wasn't sewn up, because even in front of us, the oncologist and the obstetrician were still sort of arguing the toss as to what was going to be safe or not. And it is that I think that approach, for example, came because the obstetrician at the time said, I've never dealt with a case like this. I don't know really what I'm doing. But it was his honesty, which maybe is rare. Maybe it shouldn't be, but it is. That's what led to that really open MDT approach. I met him 3 years ago when I was delivering some training to his obs and gynae trainees. And I passed him a piece of paper and I said, look, what you did for us as a family, I said, that is the standout care that we highlight. And he was like, but I didn't even know what I was doing. And that was the first time I'd seen him in 7 years. And he was like, but he said, I'd never seen a case before. I was like, yeah, but you were willing to say that. You were willing to say, I'm not best positioned to be able to make up the care plan on this, so we need everybody involved. And as a result of that, that was why our care was really, really streamlined. The midwifery, adding extra scans in for us, adding extra appointments where we could have fetal heart monitoring on the day we were due to come into chemotherapy. They're tiny things in the grand scheme of things, but I've seen it repeated over the years. we've put these ideas forward to obstetricians over the years, and they've put it in place themselves. And they say, God, that made a huge difference to that family. It handed them control back of their pregnancy when they felt like it was control was getting pulled away from them all the time. So yeah, we use that as the platform, and it always sounds a bit strange to say it, but just because Maya died, it shouldn't take away from excellent care, in the same way that you can have a fantastic cancer outcome, but your care could have been really the polar opposite of person-centered care. And I think that's why I've always used it and never hesitated, to highlight it as the good example. And thankfully, we have seen it repeated, several times over the years. We've had families where they've had, pregnancy-wise, they've had fantastic, pregnancy experiences. They felt listened to. They felt like they were just treated with utmost compassion, and they had informed choice at the end of the day. And then sometimes, sadly, you see the opposite cases where they feel like they've been shoehorned into a plan where they didn't really feel like they had an awful lot of choice. And we illustrate the different those differing situations so that they don't think it's all going to be like Maya's case, because I'm not naive enough to think that is, even if it's the same hospital.
I think honesty is always the best policy, as you said. Not everyone will have that mentality because you don't want to look like you're wrong or something like that, but that from the beginning, from any situation, whether it's oncology or not, it's really important. I mean, pregnancy in itself, not that I have children, but one day, hopefully, but lots of our friends have had problems trying to get pregnant, but even navigating that's hard. Then you have a pregnancy and then something like this happens. It's trying to bring different kind of professionals together is really hard. And I think the only little caveat, kind of just going back to what you said, where midwives trying to integrate, if you want, in oncology. So like my role as a treatment review radiographer, it didn't really exist until like 2005, but it was always nurse led. So you'd have a radiotherapy nurse. They would have all the skills, all the knowledge about how to manage the side effects, but not necessarily the radiotherapy. And then eventually we integrated and decided, well, actually radiographers can do this, but they have that radiotherapy knowledge. And then obviously that stemmed into advanced practitioners, consultants, etc. But that's similar with midwifery. I mean, nurses don't have to know enough about radiotherapy, but they can understand what's going to happen within the body. I mean, we all do anatomy, physiology, everything, but it's how kind of you recognize there's a skill gap or something, and it just grows and grows, and you push and you go forward. So yeah, I think midwifery it's an amazing profession. Just what they deal with. I think I know some people have probably watched This Is Gonna Hurt with Adam Kay, and it showcases the differences of what they see on a daily basis and the personalities they have to deal with. But Pete, you've written quite a good blog, which I've read a couple of times actually this week, which links to, I think you linked it on your Twitter account. You talk quite openly about post-traumatic stress disorder, so PTSD. What is PTSD? And if you feel comfortable sharing, I suppose, your experience around what happened.
I suppose it's an interesting question, because I suppose when it first unfolded for me, I didn't necessarily frame it as PTSD, but I guess that's probably the biggest issue with it for many people who do, no matter how much it comes about. But I suppose to delve into it, I think what I need to go back, obviously discussed earlier on about, what happened to Maya, referred to her, in the fact, obviously in the past tense, because what happened to us, I suppose unknowingly at the time, with the fact that she was diagnosed with cancer in pregnancy, and, midway through the pregnancy, even though we had all that excellent care that I described, I suppose there's two frames to that. There's Maya's timeline and how she experienced that pregnancy and what it gave to her. And at the time, obviously, I thought I was going along with that as well, and I felt that was us, and we were going through that together. But I suppose two things happened. We delivered our baby, safe and well, and he arrived, and he was really good. But the starting point for this, I guess, is probably the fact that I kind of struggled to bond initially, with my son, because my priority was like, Maya needs my care. She needs me to look after her. I just wanted to lie down and just sort of lie down with her when she was recovering from chemotherapy. And so I struggled initially with that. Like, how do I balance these two roles that I have, as that of a husband and that of a dad with a newborn baby who can't do anything for himself. Now I got into a routine, like anything, the nursery run and this, that, and the other. And then when Maya's cancer, very suddenly and abruptly became apparent that it had advanced catastrophically, because she went to the breast cancer, looking curative, and then the next thing, sinus issues started, and before we knew it, she was blurred vision and struggling to see and walk straight, and then it turned out then that she'd actually had a very aggressive spread to the meningeal lining, and from the actual diagnosis, she died 3 weeks later. So it literally unfolded at a rate of knots. There was no planning. There was no what would you like to do if, where would you like this to happen with the kids, etc. So no planning, nothing. But equally, there by the grace of God, I guess she didn't have to suffer. It was very quick, and rather than watching her decline in health over years, which I've I know many people who've had to do that. And I dealt with my grief, but my role took on. It was like I was a dad. I had two little children. I didn't really have time to sit back and actually take stock of what had happened. And before I knew it, the momentum and the idea for Mummy Star had started. So that suddenly kicked everything forward, and we, friends were furrowing around getting this idea together, and bang, Mummy Star had started. Next thing, my first anniversary came, and I kind of floated through that because there was loads of momentum around the charity. And then as the years went by, obviously Mummy Star became a more regular thing, and anniversary started to hurt a little bit more, but then everything settled down. I was fortunate enough then to, as I touched upon earlier on when we were chatting, I met my now wife Nick, who used to be my neighbour. We got together, and we very quickly became pregnant, and that was absolutely fantastic. It was something we both wanted, and we were absolutely delighted. And Nick had actually drawn my attention to it earlier on, and she just said, look, there's bound to be some difficulty here. And I was doing that, unfortunately, I will say it, but some people might disagree. I did that typically male thing. I just went, oh yeah, I'll be fine, don't worry, blah blah blah, trying to just be a bit blustery with it all. And then I think what I remember first was we went to the sonography appointment, and I think I remember getting a little bit nervous about that, thinking, right, I wonder what this is going to be like, because I couldn't remember ever seeing Merlin on screen. I remember Martha's scan in 2009 like it was yesterday. And we had the scan for Flynn, and I was trying to why can't I remember seeing Merlin on the screen? What is it that's caused this? And I went to see my counsellor, and that's when the first time, it got broached. I was like, this is the impact of trauma. This is, you did experience a trauma, and not necessarily what we were talking about, the grief. It was the fact that the cancer diagnosis happened during pregnancy. So it was a form of birth trauma, which again, is something I talk about quite a lot now with students. But that was the starting point of it. Just creates these blacknesses in your memory. You'll just there will be nothing there at all. You can't see anything. And I was like, right, okay, we'll get past that. And then, the pregnancy continued, and, I did all those things that many of us look forward to, resting my head on Nick's bump, and, singing and talking to baby, and, giving her massage and everything. And again, starts to think, I don't remember doing this with Maya when she was pregnant with Merlin. Why can't I remember these things? And then it settled down then. But what was interesting was in the midst of that period, I met a chap called Mark Williams, who's a guy from South Wales, really, really prominent campaigner on men's mental health, but particularly fathers' mental health. And I got chatting to him at a conference in Dublin purely by chance with Nick, and he was explaining to me how he'd been diagnosed with PTSD after his wife had an emergency C-section, and he obviously feared that whether she would come back or not, and he didn't deal with this for 18 months, 2 years afterwards. And that's what probably set the spark off. I thought, I wonder, is this something that I'm starting to suffer from? Is this connected to what happened years ago? And I started talking about it a little bit more, about just, make sure you check in with partners at check-ins, and when you're talking to families, irrespective of whatever's going on around the pregnancy, make sure you have direct conversations with partners. Don't just talk to the person who's giving birth. Ask direct questions to the partner rather than passively through their wife or their girlfriend, because that doesn't make you feel involved. It makes you feel more alienated from what's going on. So we went through everything. We went into labour with Flynn again. We wanted a home birth. We thought we were going to have it, and it didn't quite happen. So we ended up going in, and Nick got induced. We ended up actually getting delivered by one of the founding trustees of Mummy Star, a lady called Nicolette Peel, who had cancer years ago previously, had then retrained as a midwife because of her experiences of midwifery, and then full circle ended up actually being around. We're like, can you just nudge your shift just in case we go into labour that night? And she ended up actually being there and delivering Flynn. Bizarrely delivered Flynn on Maya's birthday, which was just utterly, wow, this is a bit strange, synchronicity, whatever you want to call it. But it felt like the kind of completion of a circle in a way for us at the time, and it was magic. And I, obviously by then, in 2018, I knew far more about like where my place was as a partner in the delivery room compared to how I had in 2009, where there was still an air of like, yeah, you just stand there and you just hold her hand and don't do anything else. I was like, get my top off. I'm having skin to skin with my child because I know this is the thing that you can do now, and it's really actively promoted. And Nick had some blood loss postnatally, so that she needed to be sort of seen to by the team. So it was like it gave me the opportunity to be able to have loads of skin to skin time with him, and it was wonderful. And it was like felt like a new experience as well. Where it really kicked in was we then went home, and obviously my perspective on the last time I had a baby was one framed by I'm the main carer. There's only me. The other person isn't physically able to do anything. And I remember sitting there one night with Flynn on my shoulder, and literally just rocking him back and forth on the sofa and everything. And unbeknownst to me, Nick apparently was over on the other chair saying, I'll take him off you if you want, if you're getting tired. And I had no idea she was talking to me. I literally had absolutely no idea she was in the room. I didn't know what the room looked like, where things were. And I was just in this weird kind of trance. It was like, why would I give my baby to somebody else? There is nobody else here to give my baby to, because the last time I had a baby, my wife was dead. So why would I hand my baby over to somebody? I'm the main carer. And I think that was the first kind of time it was like, right, there's something clearly not right here. You need to maybe sort of investigate this. And I think we had somebody around the following day, the health visitor, but again, it was one of those where the questions all went via Nick rather than sort of asking me a question as well. So it's like, how are you? And if I had been asked, I'm probably at that stage, I would have actually said, do you know what, I don't think I'm doing that great because something happened the other day. Same thing happened again a few times. Like, Flynn would have a particular cry, a particular pitch in a cry that just tells you something else. And it just threw me back to those nights where, Merlin would wake up in his cot and I wouldn't be able to know how to necessarily respond to his needs in the same way that, say, Maya would have done. And I'd be in there in the room with Flynn and I'd be trying to nurse him and trying to settle him. And I would literally I would just place him down this cot and I would just walk out at speed out of the room, flying past Nick. And she'd be like, what's the matter? And I was like, I can't deal with it. I can't deal with this. And it just threw back to those moments where it's like, but I'd normally turn to you and you're not here. And there was a few other times it happened. And then I think that the crash point was I went to University of Southampton. I actually did a talk a lot in the same program that Mark Williams, who I spoke about earlier, did. And I talked about this again alongside a chap who talks about stillbirth. And I came home from Southampton and I remember just crumpling on the sofa in pieces, just literally in tears. And I remember going to bed that night. I remember literally just curling up in the fetal position with just not wanting anybody near me. And I came downstairs the following morning. I remember sat on the bottom of the stairs, tying my shoelaces, and Nick just came over and sort of put her arm around me, and just said, "I think we know what this is, don't we?" And I think it was that thing of saying it out loud for the first time and saying, "Yeah, I think this is PTSD. This is not just trauma on its own. There's too much stuff coming back here." At times, for Nick, that was very difficult to deal with because she wants to be there for me and wants to obviously be there for Flynn as his mum. But the pain that she felt watching me going through that and knowing what the cause was of it ultimately, and I think, there were certain ways that I did deal with some of it. I had some EMDR therapy, which is like bizarre. It sounds like quackery when you say it, but then when you try it, it's actually quite miraculous. Like going back to the whole thing about Martha, say for example, in the scan. And this is the tricks that trauma can play on you. I actually wasn't looking at the screen in the end. That's what it actually opened up to. I was standing looking at Martha in the room at 3 years old as she looked at the screen to see her reaction of seeing her little brother on a telly for the first time. So I never actually saw that picture. It wasn't that I didn't remember it, because I remember the counsellor said, "And where was Martha during this whole process?" And I was thinking, where was Martha? Martha wasn't sitting at 3 years old in the hospital waiting room while me and Nick were with the sonographer. That's not how that happened. And suddenly it all unfolded. But I think what it showed, and again, why I continue to talk about it now, is that if we drag it right back to the beginning, it's that footnote of telling somebody that they have cancer when they're pregnant, even if it's not the tangible type of trauma that we typically associate with birth, like a forceps delivery, emergency C-section, sort of high-level postpartum hemorrhage, something like that. The fact that you've been told that you have something that could kill you in itself has created catastrophic thinking, but it needs to be seen as that, because if you for there on record that in somebody's notes, like when me and Nick had gone for our antenatal appointment and somebody had just written postnatal bereavement, it just would have set red flags off to say, look, you need to keep an eye on this. And it's not just limited to my situation. You could have not experienced a bereavement, but you could have had a cancer diagnosis that turned out well. But it's still a birth trauma. You could have had up to different illnesses that you could have been told you have a benign brain tumour, but it still puts limitations on the fact that you can perhaps no longer have a water birth. So I think it's recognising that birth trauma is a much bigger field potentially that we than we anticipate. And I think I've worked with some fantastic people over the years. Jan Smith is a birth trauma specialist who I've even spoken to, sort of in an unofficial, she's almost counselled me in a way in the past, of talking about how birth trauma does get so misunderstood and why we feel the need to push it away. But I think, as you touched upon at the beginning, like, what is PTSD? When I had to confront that initially, I just thought, I've known people who've been in the forces. That's, as anybody's is, my go-to was, I haven't seen people get shot. I haven't had to deal with, friends being injured. How can I possibly put myself in that bracket? But I think we are slowly but surely shifting away from that stereotypical image of what PTSD is, and the fact that it can be watching somebody get seriously injured that you love, a car crash that you saw somebody where the outcome could have been positive, but it's seeing it, the flashbacks and what it can do to you. And so it's something I think I will always be very happy to talk about it, because it's always, I think, with a view on if that helps somebody else. As my chance meeting with Mark Williams did years ago, I don't know if I hadn't met him whether I would have felt validated to talk about that, in the same way that, Maya and I had a miscarriage years ago before we had Martha. It wasn't until I met people in the birth loss and pregnancy loss world that I learned that actually it was okay to feel that I'd had a loss, for example. So I think the power of validation in meeting other people in that situation, I think, it's so undervalued, but it can really help draw out other people's experiences. And I've shared things like that with other partners since, and it really helps develop a conversation one that needs to be happening.
Can you hear me okay before I start talking?
I can, yeah.
Yes. Well, firstly, Pete, thank you so much for sharing. I know you said it's something that you're happy to talk about, but it doesn't make it any less difficult. I know we don't like to always use the term brave or courageous, but I think it is to be able to open up about it. And traditionally, as men, as we always say, we're not very good at talking about things like, oh, we'll be fine, we don't need to talk about it, and it builds and it builds and it builds, and then it becomes something even bigger, which obviously it was already quite a big thing anyway. So that building further, it's great that you got some support through counselling. How easy was it for you to make that step to get, to go to a counsellor?
I think I'd consider myself, again, I suppose going back to the male stereotypes, I would consider myself quite rare in that I've always liked counselling, and I've always seen it as a really positive thing. I think a mantra I've often sort of used with other people is, sometimes when you feel great is when you probably should go and see a counsellor, rather than waiting until you feel really, really bad, because there's always something that's good to talk about. So yeah, I think because I'd accessed counselling in the past, I didn't find it as much of a barrier. Sort of when Maya was going through her diagnosis, and I realised that was like, actually, I'm struggling to hold everything together. That was a bit of a crash. But I saw the relief on Maya's face, that it was knowing that I was going to now sort of get some support. She suddenly felt her anxiety levels drop a little bit, because she'd been trying to hold it together for me. I think counselling. I think we need to try and break it down as something that is far more informal than it's been made out to be in the past. It isn't your typical, right, you have to literally go right from the word years ago, and it's talking about, I suppose, death and parallels, for example, sort of the love that you had for the person that's died and the love that you have for somebody now. Sometimes it just takes an impartial observer to say, actually, do you know what, those two things are parallel, they don't cross over. Your love for Maya doesn't conflict with yours for Nick, and vice versa. But sometimes it's good to have that objective input in a situation. You could just be, it might not necessarily need to be something as significant as cancer, for example, or or trauma, or what we're talking about. But yeah, I think it's never a bad outlet to have. And I think what we're learning now, even as a team at Mummy Star, is to put in the benefit of, I suppose, the level just beneath that. Things like clinical supervision that you guys would have, is we've put that in place for the team as well, to say, look, we're talking about really emotive things all the time, really quite traumatic stuff, so we need to have an outlet professionally, to be able to have it as well. the trustees do like conveniently remind me and say it's great that you've got supervision for the trustee for the staff, and what about you? And I'm always like, yeah, I'll get to that one. Once I've sorted everybody else out, I'll get everybody else. I'll get myself sorted as well. But no, it is. I think it's. I can't, as you can probably tell, place a greater value on it. It's been. I won't go so far as to say for me it's been a lifesaver, but it's helped me untangle a lot of real mess that I got myself into over the years.
Yeah, and I think it's interesting how you describe trauma or PTSD. So for me, I think anyone's ever said, I've had lots of friends in the military as well. They've talked about that's PTSD, that's all it is. But actually, as you said, it could be a car crash, it could be domestic violence. So that was my experience of PTSD. And I never understood the depression, anxiety, that side of things. Obviously nothing related to cancer, but it's trauma and how it affects you growing up. I suppose it doesn't really hit you till you're an adult. So taking that first step to go. So I did cognitive behavior therapy, CBT, which was hard. I know that's a really good way to get around PTSD because it focuses on maybe one or two specific memories of trauma, and then you build on it, keep repeating it to the point where it almost normalizes what happens, and then you get through it. I know in pregnancy loss or something like that, CBT is known, I think, in evidence that it does really help. Did you find that for your children? They needed any extra support? Kind of going through it.
It's strange with the children because they have two very, very different experiences. So you have Martha was 3 3.5 at the time of Maya's death. So she has a number of tangible memories of her mum that she's can carry forward. She doesn't necessarily remember all of them as explicitly as I do, but she's recalled things over the years as she got older. I think I never realised she remembered that when Mummy died. Merlin's very, very different because he was 10 weeks old when Maya died. So his memory is one that has been developed with a narrative over the years of things that I've shared with him. That his sister has shared with him. That Nick has come into our family and embraced, and obviously they see Mummy Star everywhere. They both know the foundation of the charity is solely on Mummy, and the name of the charity is based on how I first described sort of where Mummy would be to Martha. Every bereavement specialist in the country will probably turn around and go, don't tell them that Mummy's a star. But if it works, it works, and it's something that they can explain, and it does alleviate over the years in terms of how they work out that that's the idea, and that's the spiritual aspect of it, and many of us are spiritual, and then those of us who aren't can see it in the cold light of day, which is she was here one minute and the next minute she was gone. But there wasn't any other way of describing that. I use some great literature with the kids. It's literature that I still recommend to a lot of families nowadays. But it's been, there's been times when they've had some counselling, and they've been to services to talk about about what they feel. But it's been at that age where they do an awful lot of sort of like play and craft therapy and play therapy, and to allow them the opportunity to sort of air their feelings about what it is they miss, for example. So the fact that there is a group of feelings for one and memories, and then for the other there isn't, and you can never replace that. But then arguably, is it more difficult to have older children who have had much longer memory and have even more that they actually can miss? Because we're in this strange situation now where let's say, for example, Nick has actually been part of their lives for longer than their mum was. And we're getting to this strange juncture now where Flynn is starting to ask questions about, so who's that? It's like, no, that's Martha and Merlin's mummy. And he's like, yeah, but anyway, you get these funny questions going on. Don't get me wrong, it's surrounded by love, and it's really embraced, that we've never hidden away from it. We always have talked about death and dying and cancer, and they're things that we're surrounded by as a family. I probably know more people with cancer than I do without. It's just the nature of how our life has spun in that direction compared to where it was 10 years ago. But I suppose my hope as a parent, and if I was to put my professional hat on, if I can ever call myself that, is that because the narrative is always there and it's always constantly evolving, it will help their understanding over time that this won't be a taboo subject. That if they suddenly in years to come find that a friend is diagnosed with something like cancer, that it won't hit them like a ton of bricks in the same way that it would do if, for me, when I first learnt that a family member got diagnosed with cancer years ago, where I didn't know what Macmillan was, because why would I avail of that when I've never known anybody? You know, and it's unfolding now. You know, one is going to be a teenager, the other is going to be a teenager in 3 years. They're going to go through all manner of feelings. I wouldn't be surprised if one of them really kicks back in their teenage years and says, this is unfair. You know, get the anger stage and that grief, you know, really comes out. It's an unknown. I'm in the fortunate position where I can avail of a number of services because of the people that I've come to meet over the years. You know, I've got upteen, you know, links and connections with, you know, bereavement, whether it's Fruit Fly Collective or whether it's, you know, Cruise or any of those wonderful bereavement organisations that are out there and the resources that they have. But it's, I suppose, where I would be concerned is the wider world there and other families in a similar situation is for them to know who is out there, for them to be able to reach, and also to trust your instinct as well. I think sometimes we get a little bit hung up on don't say this to children and don't say this to children, and I'm all for not saying mummy's gone to sleep, because it's a lie and there's no point in getting away from that. But I think using something that child can meet you on, I think is a little bit different in terms of where their understanding is, and you've got to do it. You know, I think there's a halfway house you can find in terms of trying to explain things like that.
Terminology is really important. I think from my background growing up in India, we're very open and honest about death and what to expect and what happened. It's still a taboo subject, but within your closed family you do have a discussion. Joe, I know you have lots of discussions with your little boy about everything.
I do. I remember having a discussion actually with a really close friend about the fact that Noah saw his grandparent pass away. And I always remember the palliative care nurse telling us as a family, you might want to be a bit quieter because she's not going to go when you are all essentially having a party. And I think it was really bizarre, because for us, we knew that that's how Nana wanted to pass away, with her whole family around her. There was music on, we were all talking, we were supporting each other. And I know she would have absolutely loved her death. It was definitely the death that she wanted. But for Noah as well, he very visibly saw someone pass away, and he will talk about it now, but he looks on it favourably. He's like, it was really nice that I got to say goodbye to Nana, and I know how someone looks when they've passed away, and he wasn't scared because we weren't scared. And I think it's really important. And I know obviously it's a very personal decision and a very personal choice for every parent, and they have to make whatever's, you know, the right decision for them. But I'm really proud of the fact that we're really open with Noah. And obviously, exactly like you, Pete, I talk about cancer all the time. So, you know, he's very much aware of what cancer is, and looking at your bodies and things like that. I suppose it's part of being a healthcare professional, but also in the industry that we're in. It essentially allows us to have conversations that I maybe wouldn't have if I wasn't.
And I think on that, I suppose that point about seeing death occur. I mean, I remember years ago having a debate at the time, going, do we take Martha to, say, for example, to see Maya once more before, you know, she inevitably will die in the next few days? And everybody else I think around me was a little bit like, oh yeah, do you want to take her in that situation? I said, from my perspective as her dad, if I don't take her, I can never give that back. If I take her and she feels traumatised by having seen her in that state of ill health, I can counsel that in some way and I can seek professional help. What I can't do is get somebody to counsel a memory that didn't exist. And that was always my perspective. I mean, yes, they didn't attend Maya's funeral, but that was because they were of the age. I mean, you know, Merlin was there in part because he was a baby, but, you know, it was. Well, their understanding of it wouldn't have made sense of it. But the flip side of that though is, you know, tears and upset and laughing and crying about situations and memories. That's always been right in front of them. You know, I've broken down countless times in front of the kids because I've got upset. God, I remember getting upset when Martha handed me a doll a few years ago and asked me to just undo, put some different clothes on it. And I was just on one of those days where I just couldn't do anything really straightforward. And I was trying to put these dungarees on this doll, and I just suddenly, just for no reason, tears started flowing. And she gave me a hug and she was like, "Are you okay?" And I said, "Yeah." And I just miss you, Mum. And I would hate to have hidden that from her. because what we're always trying to bring them both up in, and and Nick has carried this forward because she's a teacher, and she knows the importance of all this anyway, because she's very heavily focused on things like mindfulness, and it's the strength of being able to say, no, this is how we should feel, and this is what feelings look like, and tears are just part of that. When it starts to cross the border between tears becoming angry, I think that's where we need to have an intervention that's that's positive and gentle. But I think it's making it comfortable. I remember her with the Barbie years ago, where she put the Barbie into the hospital and laid it down because it was sick after having a baby. And I remember, there was a discomfort in the lounge, and I was like, oh, maybe we need to just distract her with something else. I was like, no, guys. I said, if that's what she's seeing it as, that's what she's seeing it as. What I did have to undo was, I remember visiting a baby for the first time after Maya died, and then when walking home up the road, and Martha said to me, oh, will such and such's mummy die now that she's had the baby? And I was like, no, right. I said, let's just talk about this. The baby doesn't make this happen, just in the same way that your brother didn't cause this. It's just something horrible happened at the same time, but there's not, as we would describe, there isn't causation between the two. And obviously over the years she's seen many more babies born, but she did have fears when Nick was pregnant. We thought she was coasting along with it, and then it became apparent that actually she did have some struggle, because she genuinely worried when Nick went into labour as to whether something would occur again. Weirdly, I didn't. I don't know why I didn't necessarily worry about that reoccurring for us, but obviously mine was associated with her brother and that transference. But for Martha, there was an element of I suppose of flashback in a way as to what was occurring, because it was going into pregnancy again. But then it dissipated as soon as they saw the little brother. It was just like, we've got a little brother, let's go and see him, and everything. It seemed to sort of just slowly but surely ease after that.
Pete, you talked about obviously an emotional area or challenging area that you're working with Mummy Star and your colleagues. You mentioned clinical supervision. What is clinical supervision? How does it help? And what other things do you all do to kind of look after yourselves?
Well, the idea for having supervision, I think, had probably been there for a couple of years, but it wasn't until the team grew, I think, a little bit more during the COVID period, where it was the emotional toll of because I suppose the intensity of the support we were offering families during the COVID period went up, where we saw a slight reduction in the number of new families getting in touch with us, because they weren't spending as much time in hospital to be able to get given our information the same way they would have done. But at the same time, the families that were already in touch with us, the anxiety levels went through the roof, because they were concerned about getting into hospital, having to go in there themselves. Obviously, the uncertainty about any trial medications that people were going to be going into, whether treatments would get cancelled. So the intensity went up significantly, and the team, as a result of that, they really felt it, because we have a very, very personal connection with all of our families at Mummy Star, because every family it's tailored around them and their specific circumstances. So it's not about a family coming to us and us saying, right, here's the template, this is what we offer, how do you fit into this? It's the total opposite. It's where are you at, what gestation, what's your treatment plan, when are you due to have surgery, and then potentially sort of radiotherapy afterwards. And then we'll go, right, well, within that, we think we can probably help here, and we can help you a bit here, but also, have you thought about these other things that could come up in over the space of time? Somebody gets treatment planned, they go into a whirlwind, and they can't see the wood for the trees a lot of the time. So it's trying to help unpick that for them and shape it. As a result of that, though, we develop a very, very personal connection, with families. We can often see things before they can that are going to potentially be trip hazards. One of our families said last year I think she said in a quote, one of the support workers, she said, how Rebecca used to get in touch with me before I'd even realised that I was going to have a bit of a trip. How did she's like, what kind of sorcery was this? And it's just tailoring it to get to know the person who you're supporting, putting dates in our diary to know when that woman is going to have a scan, so that she will probably be getting anxious 3 to 4 days beforehand. The insight for that comes from both the experience that we have supporting all those families, but just bizarrely the fact that most of the people that work as part of our team, they've got a direct experience of cancer in pregnancy. They've either had it themselves, they've had a partner get diagnosed while they were pregnant, or like in my case, I supported somebody, and then sort of saw them die. So they're pouring in a lot of personal insight indirectly into these families, and also then you're sort of working and supporting those people through whether they're going through whether they have, you know, a positive cancer outcome and no evidence of disease and they're on regular checks, or whether they, you know, somebody gets diagnosed with metastatic disease and they go through that roller coaster with them. And I think during COVID, obviously, the anxiety around all that went up so significantly that they just really felt it as a team. And we had, you know, we had days where we were having team meetings and there was a lot of tears, there was a lot of uncertainty, there was a lot of anxiety. It just become clearly evident, and it was like, do you know what, we've got to get something in place. So by providing that supervision environment and providing that external outlet for the team, it wasn't me that they were trying to air these feelings to, because I actually wasn't probably helpful at that point in time. I was too close to it. So they needed that external voice to be able to talk about, you know, so as a team, I guess, what they were doing, what their process is that they go through, but also where the potential, you know, trip hazards are and where they can learn to maybe pull back a little bit, but also set their own parameters, saying, you know, we can pour ourselves into everybody, but if we do that, what have we got left for ourselves? And there was also, but I think even prior to supervision coming in, what the emphasis with everybody that's always worked with us has always been, you do a support call for somebody, you get up and you walk away from the desk and you don't come back for about an hour, because you need to decompress from the fact that you have just supported that person that intensely in that space of time. Whether your thing is to take the dog for a walk, or go for a run, go and do some yoga, go and just have a walk down the river, go and do an exercise class, go and read for an hour. It doesn't matter what it is, but it's do it, and don't do it in your own time. Do it in work time. That's always been the emphasis, because people have said, "Yeah, don't worry, it's fine. I'll finish later on." It's like, no, I said, I want you to just walk away now, because it's now that the pressure is being felt. And if you carry on working and slogging it for the next 3 hours, you'll get to a point 4 hours later and you're like, oh God, that really was, you know, that was pretty full on. And also to have the clarity, I think, of reflection, to be able to go away and then sit back at the desk later on and go, right, I'm going to write this up now. What's just happened? What's my plan for the next 3 or 4 months? I do it all the time when I'm in a bit of a muddle trying to think of how to present something well, and I'll go for a run. And halfway around that reservoir, there'll just be this, oh, right, that's how it could be done. That's how to present. And then suddenly you come back 5 minutes later, presentation's just written, and that's it. But it needed that clarity of thought, and you can't get that by trying to think of something else, staring at a laptop for another 3 hours. So it's always been there. All the staff are always also given the opportunity, if ever they want to seek external counselling. It's something we fund as an organisation. It's something there for them at any point that they want, whether it's a permanent thing, whether they want it for a block of 6 weeks, it doesn't matter. It's just that the emphasis is always on making sure that we as a team are looking after ourselves first and foremost before we ever think about anybody else. And again, it stems from the fact that we are reliving some if not all of what we do. We see cases, sadly, sometimes where, as I'm sure you guys have in therapeutic radiography, you just see somebody sometimes, and you just get an instinct that it's not going to end well, and it goes against every grain that you want to, but you can just tell there's something about it. And sometimes there's cases I see, it just looks like Maya's case, and sometimes it's a fantastic outcome, and other times you just, I don't know how to describe it. There's just an inner instinct that just tells you, I don't have a good feeling about this, and you have to wrestle with that yourself, and you have to obviously hold that back. And if it works out well, then that's wonderful. But we know, sadly, sometimes with certain types of cancers that we see, when we hear somebody that got diagnosed with bowel cancer, having had 6 previous presentations at a hospital or at another health juncture, we know that the chances of that potentially metastasizing are probably getting higher by the week. And we've got to try and sort of, I suppose, keep that in check. And again, it's the easiest way is being able to air that to somebody, but also within the team as well. I mean, I think there's a lot to be said for, as much as COVID has been devastating, what it has pushed us all into forcibly is this idea of virtual time. And we meet as a team now more than we ever did prior to COVID. We never used to meet each other for 4 caseload meetings a week. We just never did it. But now our insight into our own families is so much higher, because of it. And it helps us, I suppose it helps us be there to celebrate as well, because I suppose when you reel all this back, let's not forget that we're there supporting people, through pregnancy or through new birth or, through a loss that they've experienced. So we've got to be able to be there to offer them the if something is there to be celebrated, we're often the first people that say congratulations to a new mum. That's just wrong. We shouldn't necessarily be the people that do that, but the reality is we are, and we embrace it. And it's always sad when we hear that from somebody. But equally, it's the jest in which it is said is, thank you so much for reconnecting the fact that I am a pregnant person, and that is my status is that, not that of a cancer patient. That's not my primary status in the health sphere. Mine is as a new parent. Likewise, for for somebody who's lost a baby for any manner of reasons, whether it's miscarriage, whether it was or the pregnancy had to end due to the cancer diagnosis, it's making sure that it's recognised that your primary status is that of a grieving parent. You don't suddenly become just a cancer patient because you've lost your child. That trauma will live on, but also, as a previous guest Sarah, discussed, you're contending with loss, and then potential loss in the future because of cancer treatment, because of fertility. We've got to support people through all those stages, and we want to do it. And it's obviously making sure that where we see triggers, we see it and we go, right, actually, do you know what? I might actually just give this to one of the other team. If that's the same type of cancer that person was diagnosed with, then it might be better that somebody else deals with that, because there could be some alarm bells. But we set that in stone right from the off with anybody who, any of the team that work with us. I mean, we're now a team of 8, which obviously isn't a massive team, but in the scale of what we do, that's a big jump from it being just me in my kitchen years ago, in terms of how we've developed over the years. But back then it was me supporting about 11 or 12 families. Not, a team of 8 supporting, having supported 1,500 families in the last, over a 10-year period. So, and you carry those memories. There's little things about those families that I can still remember the first time I lost a mum years ago, and I remember how devastating it felt. And that's still how we feel now when we hear one of our families, sadly has died as a result of their cancer, because we've had that connection. But just as much, as we learn with each of those families, they teach us. And I think, again, just going back to, something that Sarah said on one of your previous podcasts, I learned an awful lot about loss and how to frame loss within Mummy Star when I supported, Sarah and her family through when she lost Jacob, because I think it was about the fact that we were from the outside, it's all about pregnancy, and it was all about new birth, and it didn't really say, and if you lose your child as well, if you lose that much wanted baby, are we also there for you? So subtle changes, like the mission statement for the charity used to be supporting pregnancy through cancer and beyond. It now is cancer support in and around pregnancy, birth, loss, and and beyond, because it sadly happens. Whether it's like whatever the form, however loss occurs tragically, it should be the primary focus within that care team. The cancer's there. The cancer's going to be, we'll have a treatment plan, but that's what that family need at that moment in time. And we say this to midwives, offer all the normal care you would for a family. Normal care is normal care in loss, the bereavement care, the footprints, the handprints, the giving time with baby, not just whisking that family off to say, right, well, we've got to get this cancer treatment kick started straight away. That's not their priority for those families at that moment in time. It's what they're trying to contend with. So it's a constant learning journey, and I think the supervision was part of that learning journey in terms of, could it have been done earlier? Of course it could have done. And I've been honest about that. It should have been done earlier, but we learned, and and it is in place now. And every new sort of member of the team that will ever join us will always benefit from that as well, and see sort of why and how we prioritise it.
It sounds like an amazing place to work, and you're going to get everyone going onto the website seeing if you've got any vacancies all the time now. Pete, I know from speaking with Lisa on the last episode of the podcast, it really resonated with me when she said that she'd spoken to you personally and you said congratulations on becoming a mum, and she very vividly said that she always remembers that as being a pivotal point, because it was the first time that anyone had really kind of said that, whilst also kind of referring to her cancer diagnosis. So it, absolutely fundamental. I think it's remembering that, isn't it? And I'm just thinking about maybe people in the audience who are healthcare professionals who are focused on that cancer, and it can be really easy to just think that that patient's primary concern is going to be, you know, treating the cancer, when actually you're not. You're treating the patient, and you're having to personalise that care and consider what that person has been through. And I know Naaman and I, as part of the podcast, bleat on about it all the time around personalised holistic care, making sure that you do treat the whole person, and that includes the family and whoever else is attending with them if they have children, but also thinking about what have they been through previously. And we've had a fertility expert on the podcast, Professor Alan Pacey, MBE now, but some of his kind of thoughts and feelings around, you know, when you are supporting cancer patients and knowing maybe that they won't have children, that in itself fundamentally will obviously cause some psychological impact on going through treatment, knowing you're doing something to your body that may save your life, but it will inadvertently affect it. And, you know, if you are wanting to have children and have that taken away from you, it must be absolutely devastating, and something that in itself will cause a lot of
absolutely.
distress.
I mean, when we talk about beyond support when we start, it's exactly that. That's one of the things it encompasses. Is that, I suppose, it's this notion of grieving whilst living, you know, and that grieving that isn't always associated with, you know, with death and dying. It's that grief of, you know, who am I? What were my aspirations? Yes, we did want to grow our family, or we wanted to start a family, and because of, you know, cancer and treatment, that's now been taken away. Or, you know, my mobility. You know, in our case, you know, in terms of everybody that we support with cancer, it's that loss of femininity, the impact, you know, sort of body confidence, sex and intimacy, induced early menopause. All of these things that we don't talk about. I mean, we do, in the sense that there are more people talking about them now. Like Liz O'Riordan is just like, she's magic, in the sense of she's drawing attention to so many of these issues. You know, again, drawing on, you know, on deep personal experience. But these conversations have needed to have happened. And I think I was talking to somebody the other day, the conversation on Twitter, where, you know, these things, when somebody is say discharged, and I know the language about this is constantly changing in terms of given the all clear, no evidence of disease, whichever way we phrase that, the day we give that news to somebody, that's one day, and that is like somebody gets caught up in the whirlwind or not, of either ecstasy of, yes, this is great, I can start getting back to normal, or there's a muted, okay, but what does everything look like now? And I think we almost need another appointment then 2 weeks later to say, right, now that we've given you that news, there are other things we do need to now talk about. Symptom management. If you become symptomatic again, do you know what to do? Are you aware that the menopause is going to potentially kick in as a result of this? It's all those steps, rather than people, but people accidentally fall into them, and the next thing you're in a crisis. You're struggling in a relationship, and you can't understand why, and nobody knows what language to use around these subjects, and nobody understands why somebody isn't really celebrated because they've been told they've got no evidence of disease. Well, I'm sorry. If you were a 27-year-old woman and you would get told that, you know, everything's absolutely fine, and the next thing you find, you know, as one example, that you have literally no sex drive, that is going to hammer your confidence, along with, you know, all the other aspects of that cancer. You could have scarring, you could have, you know, you could still be living with the effects of hair loss. And it's like, why are we not putting a package of support in place to see people through this? And I'm not saying menopause is any less, you know, emotionally hammering for somebody at 55 or 65 than it would be at somebody at 25. But I suppose we need to be realistic in the sense of your expectations of what you can do in the next 10 to 15 years at that stage are going to be different. And if you're about to start a family, for example, and then suddenly you're told you can't because of menopause, or, you know, because of any of the other issues we've discussed, I think it needs a different level of attention to it than trying to deliver all of that in the same day that you're told that you've got, you know, a positive cancer outcome, or not, as the case may be. But I think we've run a series of Ask the Expert sessions over the last 12 months, trying to drill down on all of these issues, whether it's, you know, we've done them on pain management. Liz did one on sex and intimacy recently, menopause, you know, money matters, you know, all these things that creep in, returning to work. You know, what does that look like? for a different person, from one person to the next, depending on the type of cancer you've had. Some people's expectations of somebody with thyroid cancer are that, oh, well, that always has a really good curative rate, so that'll be fine, you'll be back to work in no time. It's like, well, no, not if that woman was quarantined from her baby for 2 weeks after it was born because she had to have radioiodine. That trauma will live on for years, and then you end up in this mess of, but that cancer is is the better one to get out of this one. It's like, who is coming up with this language? Cancer is cancer. It's relative to the person and their circumstances and the timing that it happens. But I think it's, I suppose it'd be an entirely different podcast for a subject on language around cancer. Let's not go down that route yet.
And don't forget, Pete, I think, everyone has one day. Oh no, there's no point saying that because it's tomorrow, but 10-year plan. Yeah. I hope everyone has commented on the 10-year plan, because absolutely everything you've commented on went in what I was writing about 10-year plan. We need long-term late effects clinics. We need the support and not that geographical postcode lottery that exists, or I'm a well-educated person who can utilise my networks and connections and, access charitable organisations. It needs to be consistent, doesn't it? And then routes for other people to access. So, I'm hoping that lots of people have commented on that 10-year plan, and then that we get a government that actions it.
I was sort of being a bit flippant with my wife about this earlier on, and said it was amazing how we suddenly were able to just magically make money appear when the COVID crisis happened. But for all the years beforehand, we didn't have that money. And now that COVID is settling, in the loosest terms of the word, or not, suddenly we have no money now to action anything, whether it's the cancer crisis, for us, we could look at both. We've got the cancer crisis and the 10-year plan on one side, and we've got the result of something like the Ockenden review last week on the other, where it's, the maternity services full stop, even before that review last week. There's not enough staff. They're leaving in droves, and it's like, how... It's the short-termism, I think, is the biggest challenge with all this, rather than saying, look, this is not going to be solved overnight. But, I was, almost sort of a bit joking about it needing a Kitchener-esque, we need you recruitment drive, but with like 5 to 7 year plan to say, yes, it's not going to be right now, but next year it will be, and try and re-recruit on a short-term basis some of those staff that are out there that do have the expertise in these areas, just to try and plug some of the gaps. But we did it during COVID. Why can't we do it now that we know the NHS is in a similar crisis, but for different health reasons?
So, Pete, we could probably talk to you all night. We have well gone over our hour. So, Pete, for anyone listening, are there any top tips you'd love for people to take away?
My main thing is seeing that person for where they come into your care, and in our cases, no matter what health discipline you are in, that person is a pregnant person first and foremost, or a new parent first and foremost. Yes, they are being treated for cancer, but that is how they see themselves, and we need to treat, and we need to support, and we need to provide the care package around them accordingly, rather than trying to push the pregnancy into the background. I think if we can achieve that, I think it lends itself to far better, sort of person-centered care long term. Even when the cancer outcomes aren't going to be positive, I think it's the fact that we set that foothold in place, and I think that carries through everything. It's almost, and I think from a cancer treatment and diagnostic perspective, it's that message that it doesn't matter who you are within whatever health discipline, is that you do have a role to play within that. Your midwife is just as capable of being the referrer, the first referrer for that person when they disclose that they're not happy with the way something feels, as the oncologist is to tell them that they do or don't have cancer, as the GP is. Everybody has a role to play within that pathway, and the main thing is just don't delay, don't refer back to somebody else to do it. If you've got it in your gift, then make that referral and see yourself as having see yourself outside your role, if you like. And it goes right back to what I said earlier when I hear midwives and student midwives say to me so regularly, but I'm just a midwife. It's like, you're not just anything. None of these roles are just anything. In the same way that you guys talk so eloquently about this, going in terms of sort of get the role known correctly, talk about it rather than just shorthandedly referring to radiography. And it's your title is therapeutic radiographer, because it encompasses so much more than purely that clinical specialism. It is that holistic view of you know of the patient and everything that is going to be impacting and affecting them in different ways. So yeah, it's probably not that succinct a way of phrasing that, but it's probably the best I can sort of put it together at the moment. Yeah, everybody has a role in this. You know, pregnancy, postnatally, it doesn't matter. It's just making sure that family are seen for where they are at that moment in time.
No, they're perfect. And Pete, if I'm out there in practice and I come across someone who has recently been diagnosed with cancer, has got a small child, how do they refer
really
to
simple,
Mummy Star?
Just email us info@mummystar.org, or you can there's referral forms, contact forms on the website that you can go straight through. There's a section for health professionals on our website. There's a referral form in there, and we're not asking you for loads of information. It's really shorthand, basic, you know, information, sort of what the situation is, what the diagnosis has been, what gestation they are. But yeah, we're not asking you to fill out reams and reams and reams of paper. It's just as quickly as we can get that family in touch with us, the better. But the important thing to remember is that we're not just there for the families, it's for the health professional as well, because you guys might see somebody like this and you're like, I've never dealt with this before, how do I? And sometimes we can just be that sounding board that you need to just say, I just need to talk about it, I just need to tell you what I'm doing. If you've got any other extra advice, tell me. And 9 times out of 10 it's like, keep doing what you're doing, but sometimes somebody needs to hear that.
Perfect. Oh, well, thank you so
pleasure.
much. As I said, we could definitely keep talking all night, but I really hope people have enjoyed that episode. So thank you all for listening to Rad Chat. Your hosts today have been myself, Jo McNamara, and Naaman Jolka Anderson. A huge thank you to our guest Pete. Head over to the YouTube page to see a live recording of this podcast. And if you're utilising the podcast for CPD purposes, please do consider the reflective questions posted alongside. We'll also link some of the resources and literature to things that we've discussed. And to receive your accredited CPD certificate, please complete the Google form that is attached to the podcast. So our next guest to feature will be Zoe Marchant, who will be discussing everything prehab, rehab and personalised care. So thank you all for listening and take care. Good night.
Thank you very much, guys.